Great. Well, thank you very much, everyone, for joining tonight, and welcome to May's Global Emergency Care Grand Round as part of Dharura. So my name is Chris Boyle. I'm an emergency medicine registrar based in Bristol, in the UK, and I'll be chairing this session today along with Rihanna, and I'll let Rihanna introduce herself here as well. You're on mute there, Rihanna. There you go.
Sorry about that. Thanks, Chris. Hello, I'm Rihanna. I am a clinical fellow in emergency medicine with global health interests at the Bristol Royal Infirmary, and very happy to be here.
Brilliant. Thanks very much, Rihanna. So before we get started and introduce our speakers, for those who haven't joined our sessions before or are relatively new to what the Grand Round is or to Dharura itself, I'll give you a sort of a background to Dharura's aims. So Dharura supports ethical, sustainable, equal, and reciprocal global emergency care health partnerships. Dharura also supports mutual development through sharing knowledge, skills, and innovations, for which the Global Emergency Care Grand Round aims to achieve. We have a wide variety of speakers and topics being shared and discussed each month, with speakers generally sharing topics across all aspects of emergency care, including case reviews, research, audit, QI, just to name a few. So we're really privileged and lucky to have two very equipped and interesting speakers today. We've got some lovely topics to share with us. But before we move on to introducing them, Rihanna's just going to go through a few of the house rules, and then we'll get started. So over to you, Rihanna.
Sure. If you can please put your mics off and cameras on if able, and if feel free to post questions in the chat, and there will be opportunity in the end to ask them after the speakers have spoken. If you could kindly post your name, location, role, and email on the chat function available. And these sessions are going to be recorded, just so that they can be available for view later on.
Great. So, as I was mentioning, we have two speakers today. The first speaker is Kephas Achiro. And Kephas, I hope I get your introduction right here because I'm currently in your LinkedIn screen and it seems very impressive. I'm gonna read it out. So Kephas is a chief registered trauma and emergency nurse with 10 years working experience with Turkana County and 1 year working experience with the Diocese of Lodwar. Currently working at Lodwar County Referral Hospital as a trauma and emergency team leader, coordinating emergency response services. In addition, he's also an emergency care champion for Turkana County and advocating music in the background.
Yeah, there is some music at the background.
Add into the introduction. So you're also an emergency care champion for Turkana County in advocating for timely and quality emergency life-saving services in Turkana. Lastly, you're an instructor at the Emergency Medicine Kenya Foundation, EMKF, who I've spent some time with as well. And you're doing a fantastic job in everything you're doing in Kenya surrounding emergency care. And you train facility staffs on emergency triage, POCUS, and the tech course. So you hold lots of skills, interests, and hobbies. And we're really grateful for you giving up your time to talk to us about sort of pre-hospital setting in Kenya. So over to you, Kephas, and if there's anything we can do, let us know. So Rihanna, if you want to share the slides for us, that's great.
Iliyochochea mada yetu ya shajara hii leo, ambapo tunaomba uweze kutuma maoni yako kuhusiana na jinsi tutakavyokomesha kadhia hii.
Right. Kephas, over to you. You should be able to see the slides, and if you can't, let us know.
Yeah, they are very clear now on my side. I think you are good to go.
Happy to go whenever you
are. Thank you so much, Chris and the team, the Dharura Global Emergency Care Organization, for organizing for this grand round CME. Just by introduction, my name is Kephas Achiro. As you can see it on the first slide, I'm a trauma and emergency specialist nurse based in Kenya, in one of the counties, one of the largest counties in Kenya, to the North Rift, called Turkana County. And my interest is on pre-hospital emergency, which is one of the greatest areas that if you see it around in Kenya, it has not been given much attention. And that is why it draws my attention. And I thought that this is the best area so far that we need to look into and invest in and make more of discussions and advocacy about the same. So to everyone on board, I take this opportunity to welcome you all. Feel free to interact. It's an interactive session, and we'll be learning from each other. I'll be happy to share, also to learn from you, give you, also you share with me your experiences on pre-hospital emergency care. But generally, the aim of this grant is to bring the Kenyan picture, not only the Turkana picture, but the Kenyan picture of the pre-hospital emergency care. Chris, I hope I'm loud enough.
Yeah, it's very, very clear from my end, Kephas. So yeah, happy enough, and feel free to move on to the next slide if you want to.
Thank you so much. So when we talk of pre-hospital emergency care, in most cases, we have been measuring on pre-hospital trauma life support care and trainings. But you will realize that pre-hospital emergency care does not entail only about trauma cases, right? We have cases that are also medical, that are medical emergencies, which are not trauma. But most cases we refer as pre-hospital emergency care based on the trauma cases, which is not the case. It covers both the critically ill, which are either medical emergencies, and also it covers on the other side, the critically injured, which refers to mostly the trauma patients. And what do we mean when we talk about the pre-hospital emergency care? It is the care that we provide to these critically ill patients or critically injured patients in a setting outside the hospital. So we can as well say it is out of the hospital emergency care services that we provide to this category of patients. And once these patients have been stabilized during the pre-hospital care, they are intended to be transferred to the most appropriate health facility for further care or evaluation. Why do you stress on the most appropriate healthcare facility? You get a case and you have stabilized this patient. Your next decision to where to refer to this patient or to transfer this patient should be a facility which is capable to provide, depending on the condition of the patient, what the patient requires. If, for example, you have a patient of head injury, which means this patient needs to go to a facility which is capable of providing head CT scan services. You cannot take a patient with head injury to a health center without a CT scan. So that is why we stress on referring or transporting this patient to the most appropriate healthcare facility, which in turn they will get the further evaluation of the cases. In pre-hospital emergency care, every second counts. Time is muscle in this case. And it is very interesting in this introductory slide. I find it interesting. You see the difference between life and death lies between the care provided before a patient reaches an hospital. So that is the care provided during this period of pre-hospital emergency care. And this is immediate medical life-saving interventions that we do at the scene, or we can offer them en route to the hospital. If you check on the pre-hospital emergency care, if we respond to these cases on a timely basis, we have realized that most of the cases that we responded to on a timely basis have high chances of survival. And the long-term recovery is also good because we usually follow and see how are the outcome of these cases that we responded to during the pre-hospital emergency response. And something which is also very crucial here is about the dispatch. This aspect of dispatch is upcoming in Kenya. And as we know, in the Kenyan setup right now, the health services is a devolved function. It is at the county level, it's not at the national level the way it used to be before. And now the question that we need to ask ourselves is that when there is an emergency, let's say it is a case of a critically ill or a critically injured patient, are we able to reach the most appropriate or the most near ambulance within the shortest time possible? Or are we able to activate the emergency medical services within the shortest time possible and get these services? So the aspect of dispatch center will come in at this point, whereby we are advocating for the community or the citizens to understand the aspect of dispatch center, whereby they can make calls. The distress calls can go to the emergency dispatch center, and then we'll be able to know the type of the emergency or the nature of emergency. We'll be able to know the severity, and also we are also interested on the location of the incident, which is very key, because from the location of the incident, this is what will enable you also to track which ambulance or which any other life-saving vehicle is nearer to that incident. And then you mobilize the response units to the scene of incident. If you check the system we have in Kenya today, someone talking? Chris?
I think that was just someone who wasn't on mute.
Okay. Thank you. So if you check the system we have today in terms of pre-hospital emergency care, you'll find it is a network of coordinated services. It is not only the county government that is providing the emergency medical care services, but we have other agencies that we are coordinating together with to ensure that we work towards the same goal or the same direction of providing timely, accessible, and quality emergency care services. And we treat these patients as quickly as possible, and then we ensure that the available resources are also used efficiently. Again, in Kenya, we have different agencies that are providing pre-hospital emergency care services. At the county level, we have said that the county level is where now the devolved function of the healthcare services has been devolved. We have the county Ministry of Health and Services, that is the county emergency medical services. And also you'll find we have the local and the regional agencies, which we'll see in the next upcoming slides, that we work together with during pre-hospital emergency response. Thank you for that slide. Now, if you see the key pre-hospital elements that we need to understand better, this is like the foundation of pre-hospital emergency care. We want to know, like, are the community or are the citizens in this country able to access the care? And how will I know that we are able to access the care? We need to understand that if an emergency occurs in an area, what will be the approach that they will give to this kind of distress calls? Do they know where to call? Are the public aware of anything like EMS system that exists in a given region? This is something that we need to advocate for. And I can give a practical example, like in area where I work, we have a dispatch center, which you'll see in the next table. Like the dispatch center and communications goes hand in hand. When there's an emergency or when we receive a distress call, that is how we refer to it, it goes direct to the dispatch center, which as a toll-free number. Then from there, we have the dispatchers. The dispatchers are well trained and certified to respond to such calls. At the dispatch center, the dispatchers are also aware of the protocols, the dispatch protocols, and there is also real-time communication with the EMS units. If you check at the dispatch protocols, you'll see like maybe you have a patient who is bleeding. There's some given instructions that you can give to the bystanders or the one has called you to be doing meanwhile as you immobilize for the appropriate ambulance to respond to such incidents. When you go at the scene, what the pre-hospital emergency response team does mostly, and this is within the shortest time possible at the scene, they do assessment, the quick assessment, the primary assessment. They do stabilization of the patients. And if it is a patient that requires basic or advanced life support services, they will also be incorporated during that process at the scene. If it is a trauma or medical management, you'll go as per the trauma protocol, or medical, you can go as per the algorithm to assist such kind of patients at the scene. After stabilization at the scene, I want to take this now patient to the most, remember we talk about the most appropriate health facility, depending with the condition that you have, or depending with the case that you have. So you need to look for the most appropriate mode of transport, whether it is ground, which is available, or you need air ambulance. And then en route, you want also to see, you do monitoring and treatment during transport, and also you do continuous patient reassessment. With these pre-hospital cases, the category of patients who are critically ill and critically injured, they are patients that you need to do continuous reassessment, even en route to the facility, because condition can change anytime. There are those patients that need close monitoring while on transit. Then once you have referred them from the scene now to the most appropriate facility after stabilization, now the aspect of handing over comes in. That is the transfer of care. We have to transfer these patients to the emergency department room or the hospital. We have some of the tools that you can use during transfer, what is called the SBA. Just give an example of the situation. It gives the background information. They want to assessments on your assessment findings, and then also your recommendations. So this is like a summarized tool that gives you the whole picture of the patient you are handling during transfer. And you can also share some of the patient history, vital signs, and treatments that you provided to such cases during the pre-hospital period. From the scene, if there is any other medications you give en route, how are the vitals monitoring? If you are monitoring this patient on route, you need also to provide this during transfer to the emergency room or the hospital. And finally, you have to document. Documentation, you understand, if not documented, it is not done. And the report. You have to do a complete patient care report. If there is any legal aspect that need to be captured, you also need to have take note of that they are also of clinical importance, because there are some cases we respond to in pre-hospital emergency care. You find that they are also being followed up by the legal institutions. Like some cases will be followed up by the DCI team. Some cases will be followed up by the road traffic police team. So you need to capture also for the aspect of clinical importance and follow-up with the team. And then documentation will also help us. When we do the review for these cases that we have responded to, we find where the gaps, where the areas that still needs to be improved on. And also we want to see this data. The data communicates. If you have data, it will give you a clear picture of areas that you need to, you have strengths on, and the areas that you still need to do some improvement on. So that's the importance of data. And it is also good for decision making. Through data, you can even use the data to resource mobilize get some resources that will help in ensuring that the pre-hospital emergency services are running smoothly without any interruption. Then there is the aspect of the medical oversight. The pre-hospital emergency medical services also as medical director, this is where they have a team. I can refer to them in a simple term like the technical working team. The technical working team that does supervision of the services that you are doing. They also review with the protocols. If you have even policies in place, they also do the review and also ensure that there is quality assurance systems in partnership. In this team, you can also have the medical team from the ministry. You can have also other teams from the other agencies or organizations that are also providing the emergency care services. That is generally the key aspect of pre-hospital emergency components. So if you understand these components, you will also be able to make it easier for you as a pre-hospital emergency care provider to know what to do in case you receive a distress call that requires your prompt response. The main aim for providing these services, emergency life-saving pre-hospital emergency care services, is to ensure that we want to respond on a timely basis, because remember, in any case of emergency, time is very crucial, or the golden hour. We want to ensure that we provide accessibility. In terms of accessibility, we want to make sure that the community or the citizens are aware on how to access these services. In case they have any case, how will I activate the emergency pre-hospital emergency care services so that we don't end up losing patients that we could have saved due to delays. I just have a picture, like in the region, locally where I am currently, we have emergency dispatch center. You can see every second counts in an emergency. So this number you can call, or it can be called by any bystander where an incident has occurred. And then we'll be able to inquire about what exactly has happened. We want to know what is the nature of emergency that you have at that given point. We want to know how severe is the case that you have. And also we want to know where is the location of the incident. So locally here in Turkana, that is a number you can call and you'll get help. And also we had another agency called Emergency E+, who are also providing emergency medical, pre-hospital emergency medical services. But they have a toll-free number you can call. But currently in our region here, they don't have an ambulance that is on standby. Initially, they used to have one, but currently it is not within the region. So we'll mostly rely on the county ambulances. And then once we receive the call, we can see we partner also with some of the private institutions that we can mobilize together and respond depending on the nature of number of casualties and also the nature of emergencies that we have received. Next slide. That is some of the emergency response numbers in the Kenyan setup, some of the organizations that are providing pre-hospital emergency care. We have the Rescue O, we have E+, we also have AR, and the numbers that you can call. We have also the St. John ambulances. We also have some called, you'll see AMREF, flying doctors. And then we have Response Med. So these are toll-free numbers, but the challenge that we have with pre-hospital emergency care services is that most of these agencies, you'll find them in major towns. But now in marginalized areas like where I am currently, it is not easy to access these services. So that is why we advocate for having a dispatch center at the county level where the locals can reach to the dispatch center, and then the dispatch team will respond to the case or the incident using the county ambulances or any other ambulance that is nearer to the scene. But we're in bigger towns like Nairobi, When you're in Mombasa, you are in Kisumu, you are in Kakamega, you can reach mostly to, I know E Plus has a good number of ambulances, you can reach to them, and then you can be assisted using those toll-free numbers. Okay, next. All agencies that provide pre-hospital emergency medical care services and personnel that are involved, we'll see a number of personnel, who are the personnel who are involved, need to have a mutual understanding of their roles. Because if you don't, if each and any personnel doesn't understand his or her role, the chances of making it a scenario become chaotic are high. And when you understand your roles, you'll also be having a smooth operations during response. And this will even reduce the chances, will increase the chances of survival for this kind of critically ill patients. I've just also captured a picture of the AMREF that I was talking about in Kenya. It is one of the agency that is providing both ground ambulance and air ambulances for pre-hospital emergency care services. And you can see the toll-free number that are shared there. You can just call the number and then you'll get assisted. The system, from the reporting, that is the bystander or anyone who has the scene, when we receive a call, you can see dispatch center, then we'll have the first responders. And also in this category, it is either the dispatch team will decide the case that we have received a distress call for. Do we need to dispatch a basic life support team and ambulance, or we need to dispatch advanced life support paramedics and also advanced life support ambulance in a advanced life support ambulance? So the information that you'll be receiving from the bystander will make you to, will help you to decide which services do you need to mobilize for a particular case. Then once you have done the stabilization and the rest, you need now to en route to the hospital for further evaluation and assessment. Next slide. You can see some images for the E Plus ambulances that are providing pre-hospital emergency care services in Kenya. Both the ground, the first one is for both the ground and the air ambulance. Below it, you can see, this is our team here in Turkana, our pre-hospital emergency care team. We responded to one of the incidents at the gold mine. This is last year. At the same scene, we also responded to another case last week. So we work as a team. We try to mobilize other agencies that are within. We have a team from Red Cross. So they usually also join our team so that we go together to the scene once we have gotten enough information to enable us to dispatch the appropriate team, whether it is a BLS team that is needed, a BLS ambulance, or we need the advanced life support ambulances to the scene. If you check the last image there, you can see that is one of our ambulances. It is a life support, advanced life support ambulance. And behind you can see a double cab for the traffic police. So once we receive the incidents, we also liaise with the traffic police. Sometimes they also reach out to and call us at the dispatch center. If they get the information prior to us, they will call us. If we get it prior to them, I will dispatch the team and also inform the traffic police or any other agency, depending on the type of incidents that we have received. It is an incident of fire. We'll also liaise with the fire brigade team. So it is a multi-agency approach. You can't just do pre-hospital emergency care services alone. However much we are rushing to stabilize these patients, you also need to take care of other factors around the pre-hospital emergency care services. I'll just have a very summarized pre-hospital emergency care system elements that give you a picture of what happens during pre-hospital emergency care. You can see, number one, we have an injured patient. Remember I started by saying we deal with critically injured patient or critically ill patients during pre-hospital emergency care response. In most cases, when you talk of pre-hospital, as I have mentioned earlier, we usually just think of trauma cases. We usually think the first thing that comes into the mind is always the pre-hospital trauma life support. But it is either, it can be a trauma case, or it can be just a medical emergency, which is not a case of trauma. So you see there's a call. The call goes to the dispatch center. The dispatch center receive the call and they interrogate the call just to get more about who is calling. We want to know what is the nature of emergency, as we have just explained prior. And also we want to know where is the location of the incident. And then from this, we want to know now which pre-hospital emergency care services in terms of which ambulance do we need to dispatch for this case. Communication goes to the team, and also the first responders also will receive a call. You can give some of the pre-hospital, before the team arrive, you can give to the bystanders, because some of the bystanders might be a first aider. You can give some instructions depending on the case that you have received. We have what is called the dispatch protocol. So the dispatch protocol will give you some of the guidelines or some of the information that we need to provide to the bystanders that they can do meanwhile as we en route to the scene. You can see there we have en route to the scene. We have ambulance travels to the patient at the scene. Then we have care at the scene, whereby care at the scene, you can see there is someone doing CPR. This is when we do the initial stabilization of the patient, depending with the case that you have already been informed by the caller, by the person who made the call during with the dispatch team. Then en route, as we had said, in one of the key components of the pre-hospital emergency care services, we need to monitor these patients, these critically ill or critically injured patients, en route to the most appropriate facility, because the conditions can change anytime. And you remember with these kind of emergencies, once you have intervened, we say you reassess. Once you have intervened for something, you need to reassess. Even while en route, you still do the same. And then we want to transfer them to the most appropriate emergency room or the most appropriate hospital, depending on what you have found as your clinical findings during your initial assessments. And then the treatment occurs in the hospital. We do follow up once we have responded to these cases. We do follow up with the cases. We want to know how was the outcome of the cases that we responded to. We want to know what was done to these patients. Did the patient went to the theater? The patient got discharged home? And all. If the patient died, we want to know what went wrong that made us to lose this kind of patients. So it is a very interesting field that once you understand it, you will just want to be there all through, just to ensure that no patient dies from preventable causes of mortality. And that time is very key to such kind of cases during pre-hospital emergency care. Next slide. As I had mentioned some of this, in pre-hospital emergency care services, we have a team of service providers. We have the emergency medical responders, who are the first responder. We have the emergency medical dispatchers. They're the ones that receive the distress call at the dispatch center, and then dispatch and mobilizes the appropriate resources. We have emergency medical technician, the EMTs. EMTs, we have both advanced and basic. We also have a paramedic in that category. We also have a category of trauma and emergency specialized nurses. And also we have trained clinical officers who are trained on emergency and critical care. So they are also part of the team that provide pre-hospital emergency care services. And then we also have the ambulance operators, commonly known as the drivers, ambulance drivers. We refer to them as ambulance operators, and they have to be trained on what is called Emergency Vehicle Operator Course, EVOC training. And then also we have the other agencies like police, as I had mentioned. We need to have the fire department also on board, depending on the case that you have. But for the case of police areas, any case you go to respond to, it is also part of your safety because you need to have security around. You need the safety start with you. So don't go to an area where you know that it's insecure without involving the necessary or the appropriate security team as well. Okay. This one is the same as the one I've just handled before. I think to just summarize again. Next slide. The key services that we provide goes in order of priority, and the most of the basic life support interventions or advanced life support intervention that we'll do, you can just give comfort and reassurance to the patients. If a case of trauma or you suspect spinal injury, you need to immobilize the C-spine. There is aspect of airway protection. You can even intubate the patient depending on the condition that you have. Aspect of IV access. You want to give IV medications, IV fluids before you transfer this patient to the nearest facility. Defibrillation. Most cases, external cardiac pacing will not be common in our setup, but our ambulances, you'll find the advanced life support ambulances are also fixed with are also equipped with the defibrillator. So a patient that need to be shocked, that one you can do even during the pre-hospital setup. Next. This is a very key important area in pre-hospital emergency care services. There are cases that you need to load and go, and there are cases that you can stay and play. Very important for this aspect of pre-hospital emergency care services. And next slide, I'm told time is going up. I just took a picture. This is an incident that happened some few weeks ago, where there were clashes between the police and also the locals in one of the counties. And you can see that is an arrowhead on that security officer. So like this case, you need to make a quick decision whether do you need to stay and play with this patient or you need to load and go with such critically ill patient, because this one you can only remove it in operating theater, operating room. So we need to transfer them to the most appropriate healthcare facility within the shortest time possible. Next. The priority patients, the poor general impression. We have patients who are unresponsive. We can have patients who are responsive but not following commands. They need to worry you. A patient with difficulty in breathing. A patient who is in shock. Complicated childbirth. We also find cases of obstetric emergencies during pre-hospital response. We receive those calls. In case of chest pain, this one also needs to be given priority. These are patients that need to be referred to a place where we can get an ECG done within the shortest time possible and interpreted. Uncontrolled bleeding, severe pain anywhere, or inability to move any part of the body. Next. The golden period is very important during pre-hospital emergency care. It is the time from the injury to definitive care. And we aim to assess and stabilize these patients and begin transporting them within the first 10 minutes. That is called the platinum 10. Treatment of shocks should have been done. And even the traumatic injuries should also ensure that you take good care of such critical action that needs to be given priority. Next slide. That is just generally again about the golden period, the first 60 minutes from the time of injury to the time the patient or these cases reach a definitive care. Discovery of incident and activation. You have the platinum 10 minutes you have talked about, and then the EMS transport these critical ill patients to the initial hospital for stabilization, for further evaluation. Next. What will you determine that this patient, when you want to transfer them, you want to know how is the condition of the patient, availability of advanced care, where is the distance, how is the distance of transport, and the local protocols within that given region. Those are some of the key points that you need to put into consideration for these cases. A few challenges that we have been facing, we have few emergency at the county levels. We have the 47 counties in Kenya. I think by now we have 6 emergency dispatch centers, courtesy of Emergency Medicine Kenya Foundation. So we still need to do a lot to have these emergency dispatch centers in other counties that are still remaining, so that the community and the local can easily access the Bristol emergency care services through the dispatch center for prompt response and good outcome. And also, we are lacking a well-established EMS coordination, a system within the county government and the stakeholders to facilitate more effective Bristol emergency care. Like, it is not that everyone will be able to call a stakeholder ambulance or any other ambulance which is not for the county and get a quick response as compared to calling the county ambulance and being responded to. There are some protocols that might have to be followed for the other organizations, so it might take time. And you see, in emergency, every seconds count. In areas like in rural areas, like area where I work, we find that the area is 60% rural and 40% urban. So most of the road networks are not in good condition. And in some areas, there is also insecurity. So this can also be a challenge leading to delay in response as compared to areas with good road networks. Also, inadequate equipped ambulances and shortage of EMS trained providers who are employed by the government. A good number of EMS trained providers are still not yet employed by the government. So sometimes it becomes a challenge during transport, during response of the Bristol cases. And also having few trauma centers across the country. We have few trauma case centers, of which, if possible, with the devolved function of the health system, we need to have at least every county as a trauma center, where that we can take these patients from the Bristol setting to the most appropriate trauma center for proper management and further evaluation. I thought I had been informed my time is over, and that is Turkana County government. That is our emergency medical care services banner. And also on the other side, you can see our advanced life support ambulance and also the basic life support ambulance with the team that we are working with hand on hand to ensure that these patients receive a timely access and quality Bristol emergency care services. Thank you so much. Time is not on our side.
Kephas, thank you very much. That was an excellent talk, and that was really insightful to do with the pre-hospital care that you are working with in Kenya. Pre-hospital care is complex. It's multifaceted, and there's a multi-agency approach. And what you're doing in Kenya to try and develop that network is really impressive. So, thank you for sharing all your developments and your experience to date. We've got a bit of time for questions, so please, if you have any, can you pop them in the chat, or please feel free to unmute and share your question with the call. That's the magic 10 seconds. So if people do have questions, please feel free to put them in the chat. I have a few. First question from me, Kephas, is you mentioned at the very beginning that you use data and to identify the timely response leading to good outcomes. I just want to know a bit more about how you collect your data around your pre-hospital cases and how you feed that back into this growing sort of pre-hospital network for me, if that's okay.
Thank you so much for that question. At the first, I have two aspects where we collected the data. You have an Excel sheet that are using to also collect the data, where we capture the patient. We don't write the name of the patient, but we just capture the initials of the patient, the age. You want to know the nature of emergency, whether it was a trauma case, was it an obstetric emergency, was it a medical emergency, and then the facility where you transported this patient to next after stabilization from the pre-hospital emergency care from the scene, and then also we follow up on the outcome from these facilities where we transfer the patients after initial stabilization at the scene. What are the outcomes? So the outcomes give us a good analysis, and you want to know which cases are we responding to most in a given period. We usually used to do weekly, but currently we are doing them on a monthly basis. So by the end of every month, we compile all the data, go through the data and see which cases were responded to most during this month. And from the outcome, were these cases also, were the patients dying, were most of them managed and discharged home in stable conditions? And if the patient died, we want to do a case of auditing with the facility team. We usually inform them to invite us so that we do the audit together. So we start from the pre-hospital aspect of it until when the patient was referred to the facility, until that time when the patient died, so that we identify what are some of the delays or some of the gaps that we need to bridge to avoid such. So we have two aspects. That is the one for the Excel sheet that I usually do using the laptop. But on the dispatch, we have the computers. You can also track. You can also print a copy of the report from the computers, and also from that report you can see the data of the cases that were responded to. It also gives you the same information about the cases that were trauma cases, the cases that were for medical emergencies, from that aspect of the dispatch aspect of it as well. I don't know if I've answered your question correctly.
No, that's great. It's really intriguing to know. I can ask you more questions about what trends you may be seeing and how you're intervening with those. But I think for me, a lot of people on this call maybe don't work in pre-hospital, but they may work in the hospital setting. So I think my next question is really to sort of open it and say, what would those in hospital do to help to gather that information to feed back into this process to encourage sort of good governance and sort of change to improve patients' outcomes. So what kind of information can they be feeding back to you to help with that process, if that makes sense?
I didn't get it clear. You want me to highlight on?
So no, sorry, it's probably my question, so apologize. So I'm really asking around, you mentioned you collecting a lot of this data around the patient outcomes, patients' care from the pre-hospital setting all the way to referral.
Yes.
And that's coming from your work pre-hospitally. A lot of people on the call may work in those hospitals. How can they help facilitate that information gathering?
Now, this is a case whereby the patient has now reached to the most appropriate facility, right? So you want to, how you can help to facilitate the process of?
In essence, sharing that information with you. What can people in the hospital do to help share that information with you best?
How they share the information with us. We have different aspects. You can, we have different facilities have different contacts that we can reach out to them. They can also reach out to us to give us the feedback of the cases that we refer to their facilities. Or we can as well call them through the dispatch number direct to those facilities and inquire more about the cases we responded to.
Great. Thanks, Kephas. Any questions in the group? I think we've got a few in the chat, so bear with me. So we've got a question from Tobogo. If you're on the call, Tobogo, do you want to unmute and ask the question yourself? So the question in the chat is, in Kenya, do you have a professional board that regulates the profession?
In Kenya, currently, Bristol Emergency Care Services, we are still just under the emergency medical services. We have policies. I'm not sure of a body, but we have policies that are guided, can you say it? We have policies that we are using under emergency medical services policies that we usually refer to, so that we ensure that we align with what the policy requires. But a specific body, for now, no.
Great, thank you. We've got a hand up. Is it Sandy in Mbweka?
Good evening. Am I audible? Good evening. Am I audible?
Yes, we can hear you, absolutely.
Yes, we are audible enough. Welcome.
Yeah, yes. It's Sandy here from South Africa. My question is more on the involvement of the government, because from your talk, I did gather that there is a huge gap and a serious need, especially in the marginalized communities. How supportive is the government, and how rapid is the government on trying to remedy the situation? Because in my understanding, pre-hospital care is actually supposed to be the first point of a connection between the government health services and the community, which now tells me that there are areas in Kenya where the government is in total disconnection with the community. And if they are unable now to bring the health services to the community, how often do they actually come to communities to actually see what the people really needs? Because at the end of the day, we can sit here and talk talk about what needs to be done, but if the important people in the puzzle are not participating, then it's not helping the communities. But my question is, how active is the government in terms of being with the EMS and assisting where they can? How does that work, my brother?
Thank you so much. That is very crucial. If you are keen enough, you remember I said in Kenya, currently we have the counties, the county governments, right? So the Ministry of Health is one of the devolved functions of the county government. So the county governments, each and every county is making efforts to ensure that they strengthen the emergency healthcare system through a partnership with other partners who are also supporting the same. Like I can give you an example of where I work here. We have the Emergency Medicine Kenya Foundation. We have the Maltesa International. But specifically for Emergency Medicine Kenya Foundation, they have been conducting trainings through partnership with the government. They have also been doing a number of capacity building. I can give you a practical example of the recent trainings that we did. The one is called Community Emergency Care Training. This is training that is majorly done to the community health promoters, because you see, the community health promoters are the ones like the ground soldiers at the community level. But if you don't have capacity building through the government support, we'll still be getting delays in activation of these Bristol emergency care services. So trainings have been done both at the facility level, but now currently we are now moving further to the community level, so that the community health promoters across other counties as well, through the support of Emergency Medicine Kenya Foundation with the county governments, also get the knowledge on the community emergency care course, which has been a very crucial aspect when it's come to Bristol emergency care services, so that they can do more of advocacy to the community members. So the government is positive and doing a lot. And the data, I can also give you the aspect of the data that we have been sharing. The government reviews the data. We have the stakeholders at the government level. We have the chief officers of health. We have the minister for health. We have other stakeholders who are the technical working group. They review the data and see through the data that there is gaps that need to be bridged. And this has helped a lot. I can say it is practical, it is working. We only just need to have more stakeholders coming in to support the program of hospital emergency care in Kenya. I think I've answered you.
Great, Kephas. Thank you very much again for sharing the topic today and for answering all the questions. There's a few more questions on the chat. If you don't mind, if you're happy to stay on the call, Chris is going to be speaking next, but if you can answer any of those questions in the chat, if you're able to, that'd be great. And I'm just going to hand you over to Rihanna to introduce the next speaker. But thanks again, Kephas, for your sharing.
Thank you so much, and welcome, Rihanna.
Thank you, Kephas. Thank you, Chris. Next up, we have Dr. Christopher Arrowsmith. Chris is a consultant in emergency medicine at the Bristol Royal Infirmary with extensive experience in emergency medicine and critical care. Chris also serves as a critical care doctor with the Great Western Air Ambulance charity. We are delighted to have you on board with us today, Chris, and thank you for joining us. Handing over to you.
Thank you very much. And I just want to say thank you to Kephas for that talk. It was a beautiful description of the pre-hospital service that you deliver. And I like the fact that the challenges you face in terms of gathering the data to direct your practice and working out which team to send to which patient are exactly the same challenges that we have in the UK on a day-to-day basis. So I recognise where you're coming from, and thank you very much for that talk, Kephas.
Thank you so much.
I'm going to try and share my screen. Let me know if this works. Has that worked?
Yeah,
working.
So you should see a head with some cogs behind it. Is that what you see?
Yes, we do.
Lovely. Okay. So in contrast to Kephas' talk about the service, I'm going to drill down a little bit and talk about two cases, specifically the cases rather than the systems and services around those cases. It's been well described already today, and it'd be as a contrast, we'll talk about the actual job themselves. This is designed, this talk, for me to stand in front of an audience and ask questions. So each slide has options. So I'm going to ask you to either unmute and shout or put in the chat or however you want. I don't mind in the slightest if I'm interrupted. Just give me an answer of what you would do when I ask the question. Does that make sense? Excellent. So my name's Chris. I'm a pre-hospital consultant as described by Anna. Thank you very much. Now, as Kephas has described, the art of pre-hospital is that you have to make very big and quick decisions with not much information. So, for example, you have a patient in front of you who is very unwell. You don't know what their background is. You don't know if they are already have diseases, if they already have injuries. You've got no idea. You've just got the person in front of you. So you have to make these very fast, time-critical decisions with very little information. So I'm going to talk through two jobs. Now, the first job for this particular job, I was not at work. I was at home. I just put my child into nursery for the day, and I had a day off, which is a rare thing. I'm sure Chris will agree. Don't tend to have many days off, but this was one of them. And my job for the day was to fix the plumbing in my house, which I'd done. And then I sat down in front of the TV, and my neighbor rang me and said, a person has been hit by a car down the road. So, day off, child in nursery, taps fixed. There has been an RTA, which is a road traffic accident, about 30 meters down the road, and there's a man trapped under the car. Now, the first question I asked the audience here is whether you would go to help or whether you would go back to the sofa and finish watching Indiana Jones, which is what I was watching that day. I won't ask you to input here, guys, because if I were to not go, it'd be a very short talk. So we're going to go down the road and we're going to see what we find. Thank you. We're going to go. Let's go. So down the road is a man trapped under a car. He has agonal breathing, so breathing very poorly and not in a way that would help to keep him alive. He's not responsive. There's a lot of people around running about panicking. There's the driver of the car who's in a state. There's a couple of bystanders, and there's a man under a car. So the first question I'm going to ask you all is, would you lift the car up or would you leave the car where it is? Or would you like me to give you more information?
More information.
More info.
Thank you, Catherine. The correct answer is always, if you're offered more info, take more info, because even if you don't make your decision, it delays it a little bit, which is great. So I'll give you a bit more information. So the gentleman in his 40s-ish, looked like a gentleman in his 40s. He is under the car, trapped. I went under the car. He has a carotid pulse, which is good, so he's not dead. He's not responding. Somebody has called our emergency response vehicles. They are on their way, and this is important. HEMS, which is a critical care service, is coming by helicopter, maybe 15, 20 minutes. A DCA, if you don't know, is an ambulance, a dual crewed ambulance. So an ambulance is 3 minutes away. And a fire team, who are the experts at lifting up cars safely, is 6 minutes away. So 3 minutes, you'll have an ambulance. 6 minutes, you'll have a fire engine and some people that can lift up cars. You've still got plenty of bystanders. So who's lifting up the car and who is leaving the car and waiting the 6 minutes until the fire team turn up?
There are a couple lifting the car in the chat.
Okay, so let's talk about lifting the car then. So
I will leave the car until
you'd leave the car?
I'd leave the car for now. The patient, yeah.
So it's Sandy, isn't it? Is that right, Sandy?
Yes, sir, yes.
Thank you, Sandy. I agree with Sandy. I think if you lift this car up and pull this man out, what are you going to do? You haven't got an ambulance, you haven't got a fire engine, and he is breathing, so there's very little you can do for him. If you lift a car up, you've got an unsafe, very heavy vehicle and a bunch of untrained and panicky people running around. If you didn't have an ambulance for half an hour, for 15 minutes, I think you might be right. Lift the car up, get the man out. But you know that in 5 minutes, some people are going to turn up who are trained at doing this very, very well and very safely. So there's no right answer, but I elected to leave the car and prepare for when the guy comes out. Ambulance arrives 2 minutes later. You've now got an ambulance, so you've got a fire engine 2 minutes away. At this point, would you lift the car? Would you continue to leave the car, knowing the guys are arriving? And if you're going to leave the car, what else are you going to do?
Leave the car.
Leave the car. And what are you going to tell the ambulance team?
They should
Let the ambulance team decide.
Okay, so the ambulance team know me and they will ask me what to do. So unfortunately, I can't put that decision off to them as much as I'd like to.
They can do initial stabilization of the patient, things like making sure the patient is calm, making sure the patient is receiving oxygen, making sure that they prepare IV lines, making sure that, yes, things
so
like
they
that.
can, I think what Sandy's saying is they can prepare for 3 minutes time when they will all of a sudden have a critically unwell patient. So get your trolley out of your truck, get your oxygen ready, get your IV lines ready. Be ready to suddenly work very fast, because 3 minutes is not very long. So, oh, hang on, let me just move the chat over here. Get equipment ready. Thank you, Karen. Exactly what I would suggest. So the fire service arrive, and one of them jumps out and says, Chris, how quickly, well, he didn't say Chris because he didn't know my name, but he said, Doctor, how quickly would you like to get this man out? And these are your options. You can say now. If you say now, the man will be out from under the car in about 5 seconds. He will be dragged out. So any injuries will get worse. You can say full spinal precautions, which will take him about 10 to 15 minutes of doing it very carefully in a controlled manner. Or you can say now, but safely, which is a bit of a fudge, and will take about 8-9 minutes probably. Okay, good. So I like the chat here. The answer is, so the answer is now because he's about to die. And although the spinal precautions are important, they're probably not as important as him continuing to live. So we're going to do it as we can, as best we can with C-spine precautions, but we're going to do it now. So I said to the ambulance crew, I would like this man on this trolley in 1 minute, and I will take all of the responsibility for this decision. So they said, the fire crew, sorry. So they said, okay, up the car went, out the man came, and onto the trolley. So you now have a man on a trolley, and he now has no pulse. So would you do CPR on this man? Would you not do CPR on this man? Or would you do something else?
There's no pulse.
No pulse.
CPR, there's nothing here.
Okay, so there is a, so okay, so I'm gonna, lovely. So we've got some debate on the chat here. So CPR is an obvious answer. Marusoi and Ashvin have said no CPR. Can I ask you why you would not do CPR? Okay, so where you can do CPR if you think that the heart is full of blood and if you want to pump it round the body. But you can also do some other things which would help you get that output back again. So for example, if this man had some tension pneumothoraxes, so air between his lung and his chest, then you need to release those before your CPR is going to be effective. If he had an empty system, so if he had bled to death, then it doesn't really matter how much CPR you deliver, you're not going to get that blood around the system. So you can do CPR, but as long as CPR does not get in the way of other things you need to be doing at the same time. Now, thankfully, you've got a team of people, so you can do some thoracostomies to release the tension in his chest at the same time as CPR. And you can put a tube into his mouth, not necessarily intubation, but an eye gel, and deliver some oxygen in. So if you have other options which might work in traumatic cardiac arrest, then you can do them at the same time as CPR. You don't have to stop everything for CPR. If it's a man walking down the street that clutches his chest and falls to the ground, absolutely, that is CPR. If it's a man who's been crushed over his chest, the chances are it's not about squeezing that blood around the body. It's probably about getting rid of some chest injuries first before that's going to work. But it's debatable, and this is why there's no right answer here. So he had a primary survey. He was not breathing. He had no palpable pulse. He had injuries to his chest where the car had rolled over him. He had injuries to his abdomen and his pelvis. No head injury that I could see, and an obvious fracture of his right arm and his shoulder. And what I did, I won't ask you to intervene here, is I put an eye gel down from the ambulance crew. I decompressed his chest on either side. And because he was completely flat, we put an IO needle into his tibia. Does everybody on the call understand those terms, and do I need to explain anything? Excellent. So just in case, an eye gel is a big supraglottic airway device that sits inside the mouth, but not quite into the trachea to deliver oxygen. chest decompressions, I think you all are aware of, and an IO is an intraosseous. Absolutely, thank you, Karen. An intraosseous needle, a metal needle that sits inside the bone to deliver the medications rather than trying to find a cannula in a particularly unwell person. We'll skip that one. So if you want to decompress his chest, then you have two choices. You can pop a needle in or you can cut it with a knife. If you have not come across this before, the correct answer here is to cut with a knife, unless you haven't got a knife, in which case you can put a needle in. If you put a needle in to decompress the chest, it will work, but then it will probably stop working in 20 minutes and have to do it again, which is fine if you want to do that. So at this point, and remember here, I'm in my jeans and t-shirt because I was sitting on the sofa. The HEMS critical care team, so my colleagues, arrived overhead in their helicopter. I live in a village called Long Ashton. In my village, there are some doctors. There are an awful lot of dermatology doctors, so skin doctors. And the ambulance, the dispatch had said there is a doctor on scene. So when my colleagues arrived, they were expecting a dermatology doctor. So when they landed, I went, oh, look, it's Chris. It was much of a lovely surprise for me. So the immediate priorities for this person: you can intubate them and deliver oxygen into their lungs. You can give them blood because they probably haven't got much blood. Or you can do more funny things to their chest to try and get more air released. Or you can do everything. What do you guys want to do?
All of the above.
All of the above. Let's do all of the above. So now you've got a good team
Do
on
it
site.
all.
You can give blood, you can get a tube down, you can do further chest intervention. Now, during this time, this man got his pulse back, which was brilliant. So he's no longer in cardiac arrest because we've released the tension that was causing his heart to not beat, and we've begun to fill him up again with blood. So the hot principles that someone's mentioned are the effective interventions in a traumatic cardiac arrest. So if your cardiac arrest is because you have been injured, these are the things that will fix you if you have them available. So replace the oxygen with intubation or an I-gel, or just getting some oxygen into them. Replace the volume they have lost with blood if you have blood. If not, any way you can replace that volume. Decompress the chest from the tension pneumothoraxes to release the pressure inside the chest and allow their heart to refill and rebeat. And then if there is blood around the heart, which might happen if you've been stabbed, but otherwise is unlikely, then you can get rid of that. Those things we teach before you concentrate on CPR in a true trauma. You can do CPR at the same time, and you probably should, because it's rare that there's a true trauma, but that's a more pressing intervention. Sandy, sorry, you had your hand up.
Well, Doc, would you not add TXA on your list?
So TXA, a clot stabilizer, will slow your breathing. Yes. So if you have it, pop it in, but it's unlikely to be the difference between life and death. If you haven't got an output, then putting TXA isn't going to help you because it will sit on the vessel that you put it into. As soon as you have an output, then giving 1 gram or 2 grams of TXA is a very good idea.
Okay.
But nice question. Thank you. Okay, so what do? We gave him blood, we gave him an ET tube, and we gave some bilateral thoracostomy, so decompression of the chest. During that time, he got his output back. So then we have to switch him to more standard critical care medicine. So we paralyzed him in case he started to twitch and remove any of the tubes. We gave him calcium, which will help with his bleeding. And we warmed them up because in the UK, it is very cold, and cold trauma patients do not do well. And then transported them to a major trauma center. As was brilliantly described a moment ago, if you don't take the right patient to the right place, if you take this patient to a center that doesn't deal with trauma, you might as well have not bothered in the first place. So pre-hospital care, as my colleague described, is about all of the pathway in the system interlinking for the patient: pre-hospital, hospital, and rehabilitation. So the outcome from this gentleman was he had bilateral flail segments, so significant chest injury and lung injury, a pelvic fracture, some shoulder fractures, had an awful lot of blood in resus, so essentially his circulating volume replaced in the resus in hospital, and lots more operations. 7 days on ITU, and then he was discharged home about 2 weeks later, and is doing very, very well. No ongoing problems. I'll talk about the second job in a moment, but just before I do, another interesting thing about this is I was on a day off. So when this man got put into an ambulance by the HEMS team, the critical care team, and taken away, I was just left standing in a road. And if you work pre-hospitally, you go to patients, you deal with patients, you take patients to hospital, and then you hand over using S-bar or something described before, and then you have closure mentally of what you've done. So you feel like that was your job complete. I really struggled here because the patient vanished and I was left with the choice of going back to my house with no idea what happened to them, which is difficult. But it's part of responding if you're not in a system that takes a patient to hospital. Okay, so second job, and I will only do 2 jobs, so I won't keep you more than about 15 minutes. But any question on that job we've just discussed before we move on to the second job?
What did you do afterwards, Chris, and how did you look after?
I switched to a PlayStation because I use computer games to turn my brain off after stressful situations. And I played Ghosts of Tsushima, which is a sword-wielding PlayStation game. And I spoke to my wife, who was in the bath, who hadn't even realised I left the house. So I can recommend it. I can recommend PlayStation if you need to dewind you, or a console if you need to turn your brain off. Anyway, so all right, we'll go for job 2. So job 2 was a road traffic accident on the M4. The M4 is a large motorway to the north of Bristol, where cars and trucks all go at an average of 70 miles per hour up and down it all day long and all through the night. On this day, I was a critical care consultant as part of a team of 3. There was a critical care doctor, that was me, a critical care paramedic, colleague, and a training critical care paramedic who is new to the job. Now, we were called by dispatch to a crash. Now, we get called to Marosoi. Sorry, just to answer your question. If the victim has visible chest injuries, is CPR still indicated? So if the patient is in cardiac arrest with visible chest injuries, priority 1 is to decompress the chest, which should take about 10 seconds. Priority 2 would then be to deliver CPR. So absolutely, please deliver CPR, but not at the detriment of decompressing the chest. Does that make sense, Marusi? It doesn't matter about rib fractures. They won't cause too much injury in CPR unless you're doing them incredibly powerfully on a small person. They might cause some bleeding and they might cause some pain, but they won't cause life-threatening injury. Thank you, Morrissey. Danielle Brown, are you talking about our second job? I'm going to assume you are. So, yes, thank you, Dan. So, okay, so let me describe. So, the dispatch said there's been a car crash. We go to a lot of car crashes. Most of them aren't too bad because cars are quite safe. But this particular one, we drove to it because it wasn't far from our helicopter base. And as we arrived, it was a pretty unpleasant scene. Scene safety is step 1. Thank you. So what we had wanted to happen was for the police to shut the road. Now, if you call the police and say, can you shut the road? They tend to kick up a fuss. If you insist on it, they're very good at it. So once you say, can you please shut the road? This is a life and limb. Someone's going to die. They'll shut the road. Shutting the M4 works out, I think, at a cost of £30 million per minute in terms of the damage it does for the economy and a road and things like that. So they really don't like doing it, but they will do it if you ask them to do it. So shut the road completely so you don't get people driving past. There is nothing more dangerous than someone driving a car past a crash and doing this. And then you have 2 crashes and more work. So we arrive on scene. It is fairly unpleasant. There is a crushed lorry. There is another crushed lorry. And between the 2 crushed lorries, there is a car, which on one side looks like a car, and on the other side looks like a matchbox. It has been completely crushed. In that car was a family of 4. the fire commander said to us as we arrived, "It's pretty bad back there," and in a white face and very frightened looking person. That's not a good sign. If the local fire commanding team say to you, "It's pretty bad back there," something pretty horrible has probably happened. So as we arrive, a female in her 40s is being pulled out of this crushed car, and they are starting CPR. There's a child in the car. There's another child on the verge, and there's an adult passenger, the father of the two children and the husband of the car, running around in a bit of a panic. And there's the two drivers of the two trucks. So we have a team of 3. Here are your options. Everybody treat the cardiac arrest of the lady in her 40s. You can split your team up. You can leave some to treat the arrest and some to go check the kids. Or you can walk the scene and make sure you've not missed anything. What would you like to do? There is no right answer here. I promise you, every answer is right and wrong.
Well, awareness of the scene is also very important. So I would start there.
All right, good. So
assign, and then
yeah. Okay, so I have
yeah.
you. I think the main feedback coming from the chat here is you would split your team, and that is what we did. Now, there's a caveat to this. Critical care teams don't like to be split. We train as a team. We work as a team. We do very little not as a team. So if you split the team, you're not separating it into 50-50. You're taking 2 people that are used to working in a pair and making them work alone. They're not as good. But in this situation, we didn't have much of a choice. So the critical care paramedic remained with the person in cardiac arrest who'd been pulled out of the car, traumatic cardiac arrest, and I walked the scene to make sure that we weren't missing anybody. So off I go. There are 6 patients in total. There are 2 truck drivers, minor injuries only, walking around. There's the car driver who has a head injury and an arm injury, but is GCS 15, walking around, shouting, worried about his kid on the verge, worried about his wife, worried about his kid in the car. There is a car passenger, the mother, who we have already discussed, is in cardiac arrest. There's the backseat child 1, who is about 8 or 9 years old, who has been extricated from the car and placed on the verge. She looks fairly normal. She has good color, good tone. She is looking around in a shocked manner, but doesn't look like she has massive injuries. And there is backseat child 2, who is completely trapped between her child seat and the front seat of the car, which has been crushed down to a fraction of its size. And all I can see is her face. Now, her face looks fine. She's about 3 years old. She's obviously terrified, but she's got open eyes. She's got normal skin tone. She's looking around. This family was Indian, and she was speaking very loudly in a language I couldn't understand. But she's looking about, and she looks all right. So those are your patients. So then I came back to the cardiac arrest, which is where the activity was. And I think someone's mentioned this. I said to the 2 truck drivers and the father, which I probably shouldn't have done, everybody that can walk needs to walk over the other side of the verge to where it is safe and stay there so we can deal with the patients we have in front of us. That would reduce our patients down to 3. Can anyone see a problem with this plan? So Karen, yeah, they are confused. But the main problem here was that the dad obviously refused to leave. Thank you. Thank you, Joy. That's Chris. That's you, isn't it? Sorry, Chris. The dad obviously refused to leave his family. He was always not going to leave his family. So that was never going to work. So we can ask him and we can tell him and we can even bring him away and he will come back to where his family are being treated. So you got to give someone that man and say, stop this man from walking into traffic. Stop this man getting the... Indeed, absolutely, Sean. Yeah, he's a useful translation and he's a useful point of history. Although at this point, he is absolutely terrified and not someone that can give us a good story. So, and now we've got this cardiac arrest. Now we do now have a pulse on this lady. which is good, but she is phenomenally unwell with big head injuries and a couple of chest injuries, mostly head. She's head-butted the inside of the car. There's a trapped child who I'm very worried about because I know nothing about this trapped child. I can't examine her. I can't see anything. I don't know. And there's a child on the verge who is talking about abdominal pain. So again, I'm going to narrate this a little bit because it gets slightly complicated rather than cutting through the reasons. But please, in the chat, put your reasons up, and I'll try to deal with them one by one. So Danielle, you can cut the child out, but she is completely crushed. This isn't a snip, snip, out she comes. This is fire pulling apart a car. Now, I was actually in the car, I was trying to assess the child when they started to do that, and I can tell you it is bloody terrifying because the car is juddering, shaking, and there is glass everywhere. So it's not a risk-free procedure. So we concentrated on the mother, and I said to my colleague, the paramedic, what's going on? And he said she needs to go to the MTC, the trauma centre. Now, unfortunately, in Bristol, we have an adult trauma centre and we have a child trauma centre. So our problem is we've got an adult going to the adult trauma centre, we've got a child going to the child trauma centre, and we've got a father/husband who can't go to both. So that's a problem, but we'll have to deal with that. We've also got a child trapped in the back of a car who we still know nothing about. So we came up with the plan to intubate the lady with the head injury and manage her head as best we could, but not to take her anywhere until we had made sure we knew that the child in the back of the car was not going to need our input as well, because there's only one critical care team there, and we can only deliver critical care to one patient when we leave the scene. The paramedic, the trainee paramedic, who is an excellent, experienced paramedic from South Africa, who happens to be one of our trainees, I asked to look after the child on the verge, and he put a cannula in her, gave her some painkillers, popped in an ambulance, scooped up the father and said to the father, take this child of yours to hospital. And both of those went to hospital. The children's hospital is next to another hospital that I work at, which isn't a trauma centre, but can deal with head injuries and arm injuries. So they went there. So we've now got this child in the back of the car and a lady who's in cardiac arrest. Who's very unwell, not in cardiac arrest. And at this point, the worst thing possible happened, and the child in the back of the car stopped responding to us and just kind of shut her eyes. So then we said, well, the priority's now shifted. The priority had been the lady. It is now the child. So fire teams, I don't care how much damage you cause, this child needs to come out. I'm going to give you 30 seconds to do this. And they cut the car apart and pulled the child out. Thank you, Karen, extricate. Thankfully, she was okay. She was just shocked, overwhelmed, and had mentally shut down because of the horrors of what she was going through. So she got popped in an ambulance with the nicest person I could find talking to her in her language, which was helpful. And she went to the children's hospital along with her sister and father were all there. At this point, the mother had been intubated and had been sent off to the adult hospital to hopefully decompress her brain and treatment there. When they arrived in the children's hospital and the adrenaline went down, they realized that the father had several breaks in his arm. And he'd been just walking around with it, not even complaining about it, because he had so overwhelmingly worried about his children and his wife. So he had just been waving this arm around with multiple fractures in it and not registering there might have been a problem. So he then got managed appropriately in the major trauma, the trauma centre. The children were married in the children's hospital with the father present, and the mother went to the MTC, and the road was reopened. The children did very well. The father did very well, and very sadly, the mother did passed away about a week or two later with her family around her bedside. So this is a sad story, but it beautifully describes how you are completely overwhelmed by patients, and you sometimes have to make very difficult decisions on where you're going to send them and how quickly you're going to get them there. I don't want to say anything else. Okay, so finally, we do have a very privileged position here in Bristol that we can pick up a phone, call 999, and you will get 3 or 4 ambulances to your door, and you will also get a critical care service flying to your garden, your front land, and helping you as best they can and taking you to hospital. And we are very privileged to be in that situation. But we do sometimes get completely outclassed and outmaneuvered by the pathologies we're faced with. And that was one of those examples. Thank you very much for listening. Hopefully that was helpful, or at least that engineered some discussion. I would like you to think about how you might have managed these patients in your environments. If it was a road in Kenya, South Africa, India, and you were the first on scene. If you were sitting at home having dinner and somebody said to you there's someone outside that's been hit by a car, how would you manage that? What decisions would you make? And where would you end up taking those people? And thank you very much for your time.
Thank you so much, Chris. This was very interesting and a very engaging presentation. Anyone have any questions? Opening the floor to questions now. Sandy's applauding for you.
Thank you, Sandy.
I actually have a question. How do you deal with differences regarding decision making given the time critical situation and given that there may be people having different decisions in the team itself?
So it's a very good question, Rihanna. Thank you. The first seniority issue is that the HEMS team, the critical care team, has primacy on the patient's care. So our team of 2, are in charge of what happens to that person. Now, we're not in charge of the scene. That's the fire. They will tell us if we can or cannot go next to that road or that bridge. And we're not in charge of forensics or weapons. That will be the police. But the patient is our responsibility. Life and limb comes first. Now, if we disagree, which does happen, then primacy goes to the doctor, because the doctor in legalese in the UK will be the person in the coroner's court answering the questions as to why they did what they did. So primacy goes to the doctor. We have top cover, which are other senior consultants that we can call. So if I disagreed with my colleague, the first thing we would do is call top cover, who's another consultant. We say, this is a situation. We find ourselves in disagreement. And can you give any advice? And they will generally give us advice, and we will go with that, because then you've got 2 against 1, if you like. But if we continue to disagree and that was not available, then it would be up to the doctor in that situation. If there were 2 doctors, it would probably be up to the senior treating clinician.
Okay, great. Thank you.
Normally, Rihanna, what happens is we disagree, we go with one person's opinion, and then later on we sit there for hours digesting why we disagreed and what we should have done.
I have a question for you, Chris, if that's okay.
Of course, mate.
So you mentioned at the very start that in thanking Kephas for his talk, that he had the same challenges in pre-hospital emergency medicine, and I just wanted to ask what processes you have, or GWAC or other pre-hospital services have in place to counter these, or sort of.
So the one of the challenges we face is we often don't know what happens to our patients, because so to explain to everyone on the call that doesn't know our region, there's quite a few hospitals that we fly patients to, and we have representation in 3 of those hospitals, very strong representation. And we can easily find out what happens to our patients in the Bristol hospitals, for example, or the Children's Hospital. But we may end up going to Oxford or Birmingham. And in those situations, we genuinely don't know what happens. So we can ring up and ask, and we might get somewhere. But there's a confidentiality issue here. They don't know us. So we're just ringing up and saying, hi, I'm the HEMS doctor. And they go, are you? And we go, yes. So they have every right to not tell us. So it's difficult to sometimes know if you got it right with what you chose to do. The other issue with this is that it's very difficult to find out what's happened to dead people. So if somebody dies, they tend to go to the coroners, they tend to have a post-mortem, but we might not hear about what happened to that. So if I think there is the classic problem we have is head versus heart. If you have a cardiac arrest, we don't know if you've had a heart attack or if you've had a big brain bleed, for example. And we'll go, head. And we'll go to the hospital and the patient will die. It's sometimes difficult for us to know if we were right or not. And if we don't know if we were right or wrong, we can't improve next time. We're still based on that on a 50-50 chance. So it would be nice if we had better liaison services with hospitals to tell us if we were right or wrong. The problem with that is there's no patient gain there. That's not helpful to that patient to tell me if I was right or wrong. So they might say, well, I don't care what that clinician thinks. It's not up to me to know what their thought is. And that's our kind of main issue. The other issue I think I mentioned is that dispatch sends us to things, and they can send us to a 100-year-old cardiac arrest in a nursing home because it's a cardiac arrest, but not to a 15-year-old person that's taken a lot of drugs and is a bit drowsy, because the dispatch hasn't recognized that the 15-year-old kid that's taken a lot of drugs and drowsy is probably more needing of our support than a 100-year-old cardiac arrest in a nursing home.
Great. Thanks very much, Chris. Just going to open the floor to everyone else on the call. I know we've run over, but if you've got any more questions, feel free to ask them in the chat or unmute. I'll give you a little bit longer to have a think if you've got any questions. Is that a question there, Ellie? So we've got a question on the chat from Karen. Karen, if you want to unmute and ask the question, feel free. Go ahead, Karen.
There. I just wanted to know if we get CPD points for these lectures, and if so, if there's any forms that we could fill in before you shut down.
Yeah, it's a good question, Karen. Thank you. So we do have certificates will be sent following feedback being completed. So that'll lead me into sort of the roundup for the session today as well, and if that's okay. So in the chat, there is a link. There's a form if you can see it, and if you can't, I'll repost it.
I've just reposted it, Chris.
Oh, brilliant. Thanks, Rihanna. So if you can fill in that feedback link, we'll be able to send you a certificate to say that you've attended today. So thank you very much for that important question, Karen, and tangent into rounding up the session. So I just want to say again, thank you very much to Kephas and to Chris for joining us today to share their time and talk about some really important and insightful topics. Thank you everyone for your participation in the call as well. It was great. We got to nearly 100 people on the call there tonight. I've always also posted a link on the group for those who aren't in the WhatsApp group or you want to share that with others. We have over nearly 250 people in the WhatsApp group, and it keeps track of the sessions going on every month and has our posts advertised in it. So feel free to add others to that group. If there's any questions, I'm sure Chris or Kephas are happy to answer them on the call or at a later date. But for now, I'm going to wind up the session because we are running a nice 40 minutes late, but I think it was well worth the time spent. So I want to reach out and say thank you very much again. Thanks for joining us, and hopefully we'll see you next month, which is Wednesday, 11th of June, and we'll be doing another grand round session. So thanks again.
Thank you. That was amazing.
Thank you, Karen.
Thanks all.